Dr. Daniel Phang is here today to share about some of the minimally invasive procedures and medications that can be used to manage these conditions so that you can enjoy a better quality of life. Dr. Daniel Phang is a qualified anesthesiologist and pain management physician. He completed his anesthesiology training in 2015 and achieved the certification in pain sonology with the World Institute of Pain in 2017. Prior to joining Singapore Pain Care Centre, Dr. Phang served as an anesthesiologist consultant in Singapore General Hospital. He was also actively involved in education, conducting regular lectures on pain management. So let's put our hands together to welcome Dr. Phang.
Hi, good afternoon. Thank you for everyone for taking your afternoon to come to listen to us. I have no funny pictures, just a lot of words, so I beg your attention. Okay, so today what we're going to talk about is pain in the elderly, but I'm going to go through a bit on definitions and what are characteristics of pain, because pain is something that is very subjective, but yet very real to us. All right, my name is Daniel. Okay, so pain as defined by the International Association for the Study of Pain is an unpleasant, is a sensory and emotional experience associated with actual or even potential tissue damage or body damage, or even described in terms of such things. So let's take a look at this definition in detail. So if the patient is unable to communicate, if the patient is bedbound, doesn't mean that they do not have pain. Pain is a learned response. So if we think about fire, right, then we immediately think of avoiding that stimulus itself. It's definitely unpleasant. It is also an emotional thing. So let's say if someone pokes you with a pin, and then you say, not pain, right? It's just unpleasant. That is not pain itself, okay? Of course, a lot of us have pain in the absence of objective illness. Now, when I talk about objective illness, a lot of illness may be like based on the MRI, based on blood tests. But increasingly, we find that there are a lot of musculoskeletal problems that can be identified with the ultrasound, with physical examination that may not be very obvious at first sight. So in this very busy slide here, I don't know if you can see, what's the difference between acute and chronic pain? Acute pain is essentially what we call simple pain. It is a protective response when we are faced with danger, when our body is faced with a threat. So for example, if we put our hand near a fireplace, we immediately withdraw our hand because it is a protective response. Chronic pain, what I tell my patients is that chronic pain is when your body's pain response has gone haywire. It lasts more than 3 months. Sometimes the body has healed and there is no objective, really no objective signs of injury, but the pain stimulus keeps carrying on. And that leads to a few maladaptive responses. It leads to lack of appetite, it leads to a loss of sleep. So as you can see, pain itself is not just simply pain transmission in the body. There is also the top-down, where your brain talks about, interprets the pain's perception. It leads to pain behaviors and the sensation of suffering. Now, is pain relevant in Singapore? What are the consequences of chronic pain? Chronic pain affects your quality of life. It affects your ability to work, it affects your ability to have what we call normal life with your family, with your loved ones. In severe cases, it may even lead to mental health illness as well. So this prevalence, if you can see in Asian adults and in the geriatric population, it's very varied, and these are in the general Asian population from the Middle East to Southeast Asian. So it can range to as high as 61%, and the elderly even up to 90%. But you know, our Asian society is very stoic, very very inward looking. We generally don't talk about pain itself. Okay, so just a breakdown of the body parts by which pain is experienced by. If we look at the reference, it's in 2009, so this is a pretty old data, but the data shouldn't have changed much over the years. So we can see that knee, followed by the lower limb and shoulder and back are the biggest areas. Finally, economic impact. So almost half of people reported that the pain affects their work. Definitely in our increasingly fast-paced society, in our increasingly in a society that uses a lot more brain power, when we are affected by pain, we're cognitively distracted. So 15% of work days can be attributed directly due to pain. And 3/4 of people taking sick leave for pain in the last 6 months needed at least 2 weeks off. Yeah, that's a bit more than paternity leave. Okay, now we come to how does pain happen? Okay, the anatomical part. So at least when you leave the lecture room, you can tell your friends, your family that, hey, we learned something today. Okay, is pain just pain? Pain, when we talk about it, is a sharp thing, right? It is burning, but how do we really describe pain? And this is important because a lot of people feel that, oh, this is just an abnormal sensation. I think it's okay. I mean, I'm not sleeping really well because of it, but we need to be aware that, okay, this is a problem and we need to identify with it. That's why we talk about this. So nociceptive pain, or what we call simple pain, is resulting from surgical, traumatic, or disease-related injuries. So let's say when you exercise, after a vigorous exercise, the next day when you're feeling muscle aches, that is simple pain, okay? Neuropathic pain is defined by pain initiated by a problem in the peripheral nerves or in the central nervous system, which includes your brain and your spinal cord. Neuropathic pain is a bit more complicated, it's a bit harder to treat, and let's take a look at the features itself before we actually know what's going on. So simple pain is sharp, it's crashing, it's tearing. So let's say when you cut yourself on the skin, you can immediately identify, yes, it's a sharp pain. When you have a tummy ache, which is what I call visceral pain, it's crampy, it's colicky. So for those who have just had a bout of diarrhea, right, you can feel that, oh, it comes, it goes, it comes, it goes, it's gripping. And then after that, once the diarrhea is gone, the pain goes away. Neuropathic pain itself is described as burning, it's electrical in nature, it's lancinating. Lancinating means you feel like you've been pierced, all right? It's shooting. A lot of people say, oh, I have shooting pain down my legs. Then now, it really, and some of you might identify with it when you have back pain, you feel like, oh, the pain goes down the back of my legs. Is it really a neuropathic pain, for example? Okay, and then sometimes with nerves itself, we know that nerves not only conduct pain impulses, it also conducts sensation. So when the nerves are injured, sometimes there's an area of excessive numbness or excessive sensitivity. When I talk about sensitivity, it's so bad that you cannot even wear clothes, you cannot even bathe, and that's extreme pain. Okay, so just a bit of anatomy here, simple anatomy. So when we talk about pain transmission, first there is a sensation over here, and then it's transmitted by nerves to the spinal cord, and then it goes up into the brain, where there is an interpretation of the pain impulses, and within the brain itself there's an emotional response and the behavioral response. Okay, now let's talk a bit about back pain and osteoporosis. Now that's what we're mostly here for, right? Why do we experience back pain and osteoporosis? As we can see, this is a picture of the backbone when you're looking in the cross section. Now the backbone has a lot of little nerves. Okay, this is an exaggerated view of the nerve supply. In real life, you can't see it so distinctively, but it's just to tell you that with the backbone itself, with most bones, it's covered by a thin layer of nerves that can cause pain. So when you take a look at an osteoporotic fracture, it is usually a bit of a crushed, wedge shape. And then you can see that when this happens, the covering of the bone is disrupted. And that's how people experience back pain from an osteoporotic compression fracture. In even worse cases, sometimes the back of it, where the spinal cord runs, okay, can be affected as well, causing pain that goes down the legs. Now, degeneration in the elderly. Why is it important? Why are we talking about this? So aging, as we know, is not even a phenomenon. It is a reality in all our lives. We are aging every day, right? Some people say life is a terminal disease, right? So increasing age, of course, brings about more opportunity in our fast-paced life, in our improved healthcare with all the scientific advances. When we age, we can do a lot more, right? We can spend more time with our loved ones. We can spend more time in business opportunities. We can explore more things that we want to do. However, if we want to do this, we need to have healthy aging, right? But we also know some people age differently. Some people look like they're 27, they're 25, but they have the body of an 80-year-old. Some 80-year-olds are healthier than most of us. They are still running marathons. So everyone ages differently. Hence, we need a supportive environment for healthy aging. And hence, that's why we develop pain management as well. We want to help to provide this supportive environment to help people improve their quality of life. Okay, so today we're talking basically about osteoporosis, osteoarthritis, and a few other general conditions itself. Okay, we're not talking about rheumatoid arthritis or pain from specific medical conditions itself. So osteoporosis. Now, osteoporosis is a very common term, very frequently heard, and it's definitely a common bone problem. This is characterized by increased bone fragility, meaning that bone is increasingly unable to support the body weight. Okay, estimated 1 in 3 women over the 50 years of age suffer osteoporosis, and is silent until the fracture occurs. Now, osteoporosis happens in not only the back, it happens in the hip as well, mainly in the weight-bearing bones. Okay, so and we know that with bone fragility, there may not even be a fall before we suffer the fracture. And as we know, when we have fractures, it prevents the person from moving because there is pain. And when a person is bed-bound, there's a lot of problems with staying in bed for long because the patient, the person who's suffering from the fall cannot breathe properly. They are more relaxed, and this leads to firstly a decrease in muscle tone. This leads to a risk of lung infection, okay? And prolonged bed rest, as some of you may know, will lead to bed sores. And once the bed sores happens, this is a risk for infection. So fractures also as a predictor for future fractures as well. So that's why osteoporosis is important and is also relevant to us, and is one thing that we can actually prevent. Okay, it decreases your quality of life, increases the financial burden. Okay, so osteoporosis can be classified in the primary causes, where it happens due to the body absorbing and replacing the bone, or secondary. Secondary can be due to a cause, a disease, or usually due to disease, but sometimes like other causes could be like accidents and things like that. So primary can be firstly divided into a lack of estrogen for women, or type 2. Type 2 is usually elderly. So in the extreme elderly, the 80, 90-year-olds, even though you're male, there is also a chance for osteoporosis. The other thing, with elderly, a lot of them take a lot of medication. And what we call polypharmacy means that they take too much medication, and this increases the likelihood of falls because some of these medication may increase the risk of sedation. So how do we diagnose osteoporosis? We have heard of the bone mineral density test. Now I apologize for the lack of the picture quality there. So anyway, it's a bone mineral density test. Is actually a very quick type of X-ray test to look at the bone mineral density. Now there is no international guidelines on how often you need to repeat this test, but locally, most people would say about 3 years would be a good predictor. And this repeat test shows whether the treatment has been helpful or not. Okay, osteoarthritis. Now, osteo just means bone, right? Osteoporosis, porosis means there are holes in it. Arthritis means the joints are a bit inflamed, causing pain. So osteoarthritis, degenerative changes within and around the joint. This happens mostly with sportsmen, with elderly as well, because as we age, there is increased stress and inflammation around the joint. The cartilage is eroded, the joint space decreases. Most of us suffering from osteoarthritis have joint stiffness. There is increased pain on activity, and sometimes when you move your joint, especially your knee, there's this thing called crepitus. Crepitus is not just like cracking of the knee, but when you move, you actually feel like there's a bit more like friction in the knee itself. Okay, so other general problems that we face are musculoskeletal ailments. Now, what are these? Degenerative changes in the elderly are not confined to just the bone density. Everything slows down. Everything also, the function also slows down as well. So the ligaments, the muscle tone, everything becomes lower. Everything becomes looser. Coupled with dietary changes, some of them might become bedbound, might end up having a liquid diet. So this also adds to the muscle tone and the ligament laxity. Some elderly might become obese as well. And why is obesity important? Because obesity can actually cause compression in nerves. So let's say, for example, some people do not know we have a big nerve that runs down the front of the thigh here. And a lot of very obese patients that we see may be elderly, and when the obese tummy overlaps onto the thigh, this can cause compression in the thigh, and they present with this thigh pain, or they even do not know it's a thigh pain, they call it hip pain. So hence that's why pain management requires a very specific look at each patient, and individualized treatments then can be instituted. Elderly have a fall risk. This, again, increased the musculoskeletal problems that they have. While fall risk, I'm talking about like ankle sprains, for example, right? Plantar fasciitis, heel pain. Okay, now coming to treatment. Why do we want to treat? So a lot of us in the Asian population, we want to avoid medication. Right? We want to try, nowadays everyone wants to try to avoid seeing a doctor, want to try the most natural way of healing, okay? So that's why all of us have this innate sense to want to treat the underlying problem, be it osteoporosis or arthritis. So we want to treat because we want to help the person suffering to mobilize, to move. We want to improve their quality of life. Now, some of these problems cannot be solved without maybe definitive surgery. Let's say if you have a fully torn ligament, for example, a fully torn tendon, the definitive treatment is still surgery. But let's say if the patient is so elderly, or if the family thinks that surgery might be a danger to the person's life, then we can treat the underlying pain to improve the quality of life. We are not numbing the patient from the pain itself. Okay, it's a slightly different perspective. And of course, when we facilitate mobility, when the pain sufferer can move, it reduces the morbidity, it reduces the mortality, it reduces the burden on the family, and so forth. Okay, and treatment can be simply divided into three, or rather, the fourth one is actually psychological treatment. Okay, but most of us, we talk about medication, we talk about intervention, we talk about lifestyle changes. Now, intervention is more of, in the Western context, is more surgical, but today I'm going to talk about a step back from surgical treatment. So let's talk about medication first. The broad classes, everyone knows Panadol, right? Everyone knows what are, okay, most people don't know what NSAIDs are, but NSAIDs are actually things like Voltaren, diclofenac, naproxen, and even aspirin. Okay, this very difficult word here is what we call acoxia. Yes, I hear some of you saying that. Celebrex. Okay, these are the two main COX-2 inhibitors in the market right now. Okay, and generally, if you see a GP or even a surgeon or any other doctors, they might just call it an anti-inflammatory. Okay. A weak opioid. Okay, a weak opioid would be that of Tramadol, okay, or even codeine. So I'll come to it in a while. So these are weak opioids. And your strong opioids like your morphine, or even some of you might have heard of fentanyl patches, or even oxycodone. These are more prescribed by a specialist level in the hospital itself, either by a cancer pain doctor or a pain specialist like myself. So combination therapy. Now, why are we talking about combination therapy? Because we know that when you take Panadol and you add Arcoxia, for example, the effect is a lot better. I always tell the patients, it's not 1 + 1 = 2. The effect is 1 + 1 = 3, it's equals to 4. So now in the market, currently we have a few combination therapy medication. One is Panadine, it's Panadol with codeine. And then one is Ultraset. Ultraset now, like in SGH, only the cancer center prescribes it. All right, it's essentially Panadol with Tramadol. Now, the latest one that's come out is this very weird name called Skudexa. Skudexa is essentially ketoprofen, a derivative of ketoprofen with Tramadol. Okay, so you might want to ask your family doctors about it if it's going to be helpful as well. Okay, and because it's a rather new medication, so maybe the awareness is not very much out there. So you're one of the first few in the public to actually know about this new drug. So we talk about topicals. Why are topicals important? Because a lot of us don't want to take medication, right? We don't want to suffer the side effects. Every one of us know that when we take Arcoxia, when we take Voltaren, when we take naproxen, we are at risk of gastritis. We're at risk of heart problems. We're at risk of kidney problems as well. So everyone wants to talk about topicals. Now, topicals, there is your Flexi-Sec. Okay, Flexi-Sec is a cream where you put to help. It's believed to penetrate the bones and to help lubricate the joints. Okay. Now, topicals are useful for superficial ailments. So let's say you have a muscle pain, you have a ligament tear, you have a tendon tear. These are useful. Now, if you have back pain, okay, sometimes it's useful. Why do I say sometimes? Because back pain, there is always a component of muscle. There's always a component of the muscle causing the pain. Why is that so? Because when you are in pain, your body tries to protect itself, it seizes up. So when you seize up, you tighten yourself, your muscles goes into a bit of a spasm, and these topicals are useful to help to relieve that component of the pain itself. Finally, adjunct medications. Now, adjunct medications is a huge family, okay? So we talk about osteoporosis first. Adjuncts would be calcium, vitamin D, supplements. Now, how much calcium should I take? How much vitamin D should I take? Previously, a lot of recommendations said, more than 1,000 milligrams of calcium a day is fine. Just don't exceed too much, like 1,600, 2,000, because that would increase your side effects of renal stones, or maybe even like abnormal heart rhythms and things like that. But in the recent years, maybe 2 or 3 years ago, they've said if you're mobile, if you're still moving around, don't take more than 1,000 milligrams of calcium a day. Okay, what's the difference between like the usual calcium carbonate, the cheapest one, versus some other more expensive ones? Now, the more expensive ones, you might need to take more, but it reduces the side effects of like tummy upset and things like that. Okay, so vitamin D, they say no more than 300 to 400 units a day. Okay, so but if you are going out in the sun, we've been having very sunny days recently, that is usually a bit more than enough. You just take a bit more oral supplementation with like fortified milk, fish, right? These are all good supplements. Other treatments, adjunct treatments in osteoporosis would be that of the medication that helps with the bone and how the bone is metabolized by the body. So there's a big class that's called the bone. They prevent the bone from getting absorbed by the body. Okay, we know that when the bone is a steady state between calcium deposition and calcium absorption by the body. So as we age, the calcium absorption takes over quite a lot because the deposition part just slows down. Okay, so to reduce the absorption part, there is the bisphosphonates. Okay, things like the residronate acid, alendronic acid. These are some of the common terms you might have heard of. as well as this other new drug called the denosumab. Okay, it is essentially an antibody that helps to reduce the absorption of bone in the body. There is another class that increases the bone deposition in the body, and that is more of like a hormone. Okay, don't be too afraid when you talk about hormonal therapy, but this is actually now recommended almost to be first line. Okay, but these two last drugs, medications that I mentioned, or rather their injections, are a bit more expensive due to being new in the market. Other adjunctive medications are more for chronic neuropathic pain. So let me just, I won't talk too much about them, okay, because in the primary care, they might not, your family doctor may not prescribe them so much. But essentially, most of them are prescribed, or rather initially formed as mood medications, antidepressants, for example. But they've also been found to be useful for such chronic pain states. Okay, so mention those. All right, so interventional therapy. Now, when we talk about interventional therapy, a lot of people just think about physiotherapy, and then after that, straight to surgery. Now, pain management comes in between when physiotherapy and your massage therapy or whatever, physical therapy has failed, and maybe some people do not want to go for surgery, or maybe it's a bridge before surgery. So let's say if the waiting time for knee replacement is too long, or the patient is too sick, we can do something to help with the pain around the knee itself. Okay, so I have pictures of just the back itself, because back pain is very relevant for most of us. Okay, we do quite a bit of back pain, and what we do is we use an X-ray to see the back, and then we direct the needle there. Okay, it is not a blind injection that most doctors do. It is not just putting a needle in where we feel the pain is. Okay, it is image guided, and we inject a variety of medication, mostly local anesthetic, sometimes a tiny bit of steroids. Okay, the steroids being deposited in the area itself, we do not see what we call the bodily effects of long-term steroids. Sometimes with these needles, we run electrical impulses to what we call, in very layman's term, to burn the nerve. But essentially what it does is to deactivate the nerve impulses to block off the pain sensation. Now, I want to talk a bit about ultrasound guidance. Again, the picture quality is low. The ultrasound guidance is something that's been coming into fashion maybe in the last half a decade or so. Increasingly, we have a handful of pain doctors who are well-versed in using ultrasound to direct the needle into areas of pain. For example, if you have knee pain, you have a shoulder pain, for example, most family physicians will feel around the shoulder girdle and put a needle in. So what we do is we use ultrasound, we see the muscle layers, we see where the bone is, we avoid the arteries, we can avoid the big nerves when we put the needle in. So this is essentially live. We can see, the patient can see where the needle is going. We can also confirm the needle placement with the medication that we inject. So it's more accurate, it's probably also safer. All right, so what can we on our end do? So lifestyle changes, physical therapy. So physiotherapy, aquatherapy is just a simple term for going to the pool, walking around, exercising the core, simple exercises that most times the physiotherapist will prescribe. Acupuncture and chiropractic manipulation is also something very popular in our local context. Okay, and dietary change. So we always advocate if you have a very I don't like to use the word obese. I also don't like to use the word fat, but sometimes we have to use it. So dietary changes can help reduce chronic pain states as well. Okay, so that's essentially the talk. A lot of information there, but I hope it was useful. Okay, I'll take questions. I'm not flying off. Yeah. We have the whole afternoon. Yes. Oh, okay. How do we treat plantar fasciitis? Okay, so let me first say, when we talk about specific conditions itself, it needs to be, every individual patient presents slightly differently. So whatever a family physician has mentioned as a possible cause of pain, sometimes the cause may not be the same. So when we talk about plantar fasciitis, let's talk about heel pain itself. Now, plantar fasciitis, when we talk, how do we treat it? It is from very simple, we talk about stretching. We want to mobilize the tissue. We talk about heat packs, cold packs. We talk about simple medications like naproxen. These are things that can be done. On our end, what do we do? So let's say if the patient has not responded to these treatments, what I will do is I will use the ultrasound. I will put a needle where the what we call the fascia or the tissue starts in the heel, and I will deposit some medication. Now, what medication do we deposit? Okay, there are two options. The cheaper option would be local anesthetic and a bit of steroids. Now, why steroids? This has been since the beginning of medicine. When you inject a bit of local anesthetic and steroids in the joint, it relieves the pain, you can mobilize it, the recovery is good. Okay, so that's what we do. The second option is what we call regenerative medicine. Now, it's not a magic bullet, but essentially what it does is we take a bit of the blood, we spin it down, and then when we spin down, the red blood cells all the red blood cells settle to the bottom, and the yellow liquid left is what we call plasma. And that bit of plasma is rich in what we call healing factors or regenerative factors that we will inject into the tissue itself to help facilitate and promote healing. Okay, so that is how I would treat plantar fasciitis, and to help you recover. To help you walk almost immediately. Sometimes I'll even deposit a bit of local anesthetic into the ankle nerves itself to reduce the level of pain, so that when you go back to your physiotherapy, you can facilitate it a bit better, because a lot of people cannot do physiotherapy because they have pain. Then it's a vicious cycle, right? So you have pain, you cannot do physical therapy, but you need physical therapy to help with the pain. So there you go. What are the side effects of person taking at least 2 Tramadol tablets and 4 Panadol per day to control the pain every day for more than 3 years? Okay. Okay, so when you take medication for more than 3 years, especially something like Tramadol, okay, there might be a bit of tolerance. Tolerance means the body may need more medication to help with the pain. So suddenly you feel like, oh, I'm taking a lot more to help with the pain. So if you have taken 2 Tramadol tablets consistently for 3 years, the tolerance is very minimal. Tramadol, the bigger side effects is nausea and vomiting. Okay, so if you don't have that for 3 years now, it's okay. Tramadol the dose, I do not know how much is it, but I'm assuming it's 150 milligrams per tablet, so it's 100 milligrams a day, which is still pretty low. Most Asian young adults, I will start with 50 milligrams, 2 times, 3 times a day. Okay, so 2 tablets a day is actually pretty low. Four Panadol tablets, so let's say this is the standard 5 milligram tablets. So 4 tablets a day would be 2 grams, which is also still very low. Okay, I generally tell patients don't exceed more than 6 to 8 grams a day. Okay, if you have kidney problems, you have liver problems, then you should cut down to maybe 4 to 5 grams a day. Okay, but most of the time, 4 tablets of Panadol a day for 3 years is very safe. Now, to convince the skeptics out there, our liver has a very high capacity for metabolizing paracetamol or Panadol, for example. So 4 tablets a day is very safe, okay? So we're not talking about the anti-inflammatories here, because the anti-inflammatories definitely is a black box that if we want to talk about side effects, we can talk about it all day long. Is climbing stairs good for the knee? It depends, okay? Now, it depends on how reversible the knee condition is. If you have a sprained knee, for example, I see some young folks here, rehabilitating the knee by strengthening the muscles around it is definitely good. But if you have a degenerative knee condition, for example, osteoarthritis, now this might cause more pain than not, right? And sometimes when you mobilize the knee too much when it's already degenerative, it will accelerate the problem. Now, I'm not advocating bed rest, okay? Keeping a bit of mobility is always good, but when you have pain, it always affects the mobility. So climbing stairs is also affected when you have a meniscus, okay? For those who know, the meniscus is like the cushion in the knee joint. If it's torn, the knee is not stable, and climbing stairs is definitely very painful. Even coming downstairs is very painful. So in general, yes, climbing stairs is good for the knee because you are strengthening the muscles around it, okay? But based on the certain conditions that I said, if it's not a degenerative thing, there is no soft tissue in the knee that's flapping around, causing more pain and instability. Is it true that our knee cartilage can regenerate by exercising? Now, this is a tricky thing. I would say that the knee cartilage, sorry, my hands are numb. Okay, the cartilage in the knee has very poor blood supply. So we need to think about, when we think about pain conditions, I always encourage the patients to go back to the basics of how do these things happen. So we talk about the cartilage. How does healing happen? Healing happens when there is blood supply, because the blood brings oxygen, the blood brings nutrients. Now, in our cartilage, in our tendons, in our ligaments, the blood supply is poor. It depends on what we call diffusion. Okay, so if you think about it, this is the area of pain, right? So if you have your delivery truck here, the healing happens very fast. But if your delivery truck or your blood supply is not here, but is right over there, okay, it takes time for the oxygen and nutrients to slowly move across, which is what we call diffusion, right? From an area of high concentration to low concentration. So that takes time. And in a high use, well, the questions keep increasing. In a high use joint like the knee, for example, okay, the stress on the knee is definitely going to be a lot faster than the amount of healing that can take place, even in the elbow, for example, right? So, in general, the answer is no. The exercise cannot regenerate the cartilage. Okay, exercise. I would say exercise will strengthen the knee. It will improve the bodily awareness to how the knee moves in respect to the whole body. Now, why is this awareness important? Because we need to be aware of how our posture is, especially for those with back pain and hip pain. Posture is very important to help to reduce the area of pain. Okay, so no, knee cartilage cannot be regenerated by exercising. There are some injections, what we call, some of you might have heard Synvis, Monovis, Orthovis. These are just derivatives of the fluid in the knee itself, okay, manufactured from certain animal products and injected into the knee. This is to stimulate the cushioning fluid in the knee itself. This is to stimulate cartilage regeneration, but in general, that regeneration is very slow, okay? So even with regenerative medicine, which I just mentioned, with that purified amount of plasma, and even sometimes they say that with bone marrow, this can stimulate the cartilage regeneration, but I would say the evidence is still not strong, okay? So I would say these are more pain relieving, pain management therapies than really regenerating the cartilage. Does Tramadol, a painkiller, trigger or worsen reflux? Okay, this is a very personal patient individual problems. I've always tell patients, wrong. Tramadol, if you think about it, it acts on the what we call the opioid system and a bit of the other systems, pain systems in the body, in the brain and the spinal cord. So it doesn't act on the stomach. It doesn't act on reducing the stomach lining or hurt the stomach lining. So it shouldn't cause gastric pain. It shouldn't cause worsen the reflux. But I have patients who have said that they have worsened reflux from Tramadol. Okay, so this is what we call a very rare patient-specific side effect. Okay, it is not a big side effect that I would tell patients. It's not so common. I will always tell patients the most common for Tramadol will be nausea and vomiting first. Wow. Suddenly all the questions change. Okay, it is better to ignore pain or to take medication to ease the pain. Okay, so this is a tricky question because things like headache, for example, if you've been having a headache on and off, and for most of us, I would say that Singaporeans are very intelligent, right? We always identify the cause and the effect. So if your headache is caused by a busy day, it's caused by your children screaming at you, it's caused by your boss screaming at you, then it's usually a tension headache, nothing to worry about. You've read about headaches that are like what we call thunderclap headaches, the most painful headaches that you've ever had in your life, or headaches that cause weakness, accompanied by constitutional symptoms like night sweats, half your body looking strange, right? Your eyes deviating. These are what we call neurological symptoms. Those are things that you need to seek treatment. Okay. Now, do we ignore the pain? I would say it is a very difficult question to answer because, like we say, we want to improve the quality of life, but we know that some of these problems cannot be solved by conventional medical treatment. So I would assume that most people would have sought the opinion of an orthopedic surgeon first, or a general physician, or even sometimes a rheumatologist to see if there is anything that can be solved, anything medically that can be solved. So these reversible conditions are usually treated, and then when they come to us, it is usually the tendon injuries, the sprains, the sports injuries, the back pain that has not been solved by all these that we need to start pain medication or start pain treatment. So we are not asking you to ignore the pain. We are actually lessening the pain to, again, improve your quality of life. Okay. What are the long-term side effects if a patient is taking many types of painkillers to ease? Okay, long-term side effects. So now again, this is a very general question. When we talk about painkillers, okay, let's talk about the nastiest, okay, the anti-inflammatories. So if you take it every day with no stomach lining protector medication, what we call omeprazole, there's a high chance that you can develop gastric ulcers from it. Okay, gastric ulcers, some people say, oh, just tummy pain, right? No, gastric ulcers in severe cases can lead to excessive bleeding, can lead to, death. Okay, so why do they keep changing? Okay, so can people be addicted? Okay, addiction, no. Okay, but Tramadol, for example, let's be very open here. The WHO did propose to put Tramadol on the controlled drug list. That means with the same class as the morphine and fentanyl, because they read in various countries that Tramadol trafficking and side effects of Tramadol reporting has gone up. So they suspect that this is a Tramadol abuse problem. Now, we don't have any numbers to suggest that there is a Tramadol addiction in Singapore, but with, like the previous question, 2 tablets of Tramadol a day for 3 years is not going to cause any addiction, okay? So, most of the time, no. But if you are on fentanyl, you are on morphine, you are on all these opioid medications, then I wouldn't say addiction, because addiction is more of a social problem. I'll talk about tolerance. Yes, you can develop tolerance, meaning you need more medication to ease the pain itself. As a pain doctor, most of us don't like to prescribe opioids unless it's really a terminally ill patient, and this is actually what the international guidelines go by, okay? So, okay, I answered the second part. Does Tramadol, a painkiller, trigger? Okay, we answered that. Okay, will long-term Bangor or Fastum even worsen acid reflux? Generally, no, because we think about it, it acts on the locally to reduce inflammation, to reduce what we call the inflammatory soup causing the pain itself. So generally, no. Okay. Of course, if you bathe in Bengal and Fastum gel in a bathtub, you will definitely absorb more and definitely increase the risk of acid reflux. Okay, how does FlexiSec work? Okay, this you should ask our friends outside. Okay, but essentially it is the cream. If we talk about the cream itself in the microscopic realm, they have all these little things to help to transport the the cartilage lubricant across the skin, because skin is a barrier to medication absorption. So it's always a bit troublesome to transport any painkiller across the skin to the site of action. Okay, so FlexiSec has that transport carrier in the cream to increase the absorption by the body so that more of the lubricant can go into the joint. Okay, simple enough? Okay, great. All right. What? How safe is arcoxia? Okay. Arcoxia is okay, let's talk about the COX-2 inhibitors, okay? COX-2 inhibitors, the first few were taken off the market because they thought that they increased the risk of heart problems. And these were in trials, and some of these were already in the market itself, and they took it off. Okay, arcoxia came a lot later. Arcoxia definitely will have heart side effects if already the patient has like a heart attack before, he has a blocked coronaries. This will definitely increase his risk of a heart attack. Okay, if you are young, if you are healthy, arcoxia shouldn't increase your risk of heart attacks compared to another anti-inflammatory. So if you take a young 20-year-old and start him on arcoxia for 20 years or naproxen for 20 years, the cardiovascular side effects should be the same. Okay, but yes, when you start arcoxia, cardiovascular or the heart side effects is there. Okay, kidney also. So if the patient is really on like dialysis, for example, most of us will not start the patient on arcoxia because that can accelerate kidney failure. Okay, and definitely the risk of causing gastric ulcers is no different from the kidney side profile effects are no different from all your other anti-inflammatories, but arcoxia is safer for peptic ulcer disease. So that means it does reduce the risk of causing gastritis. Okay, we do have a couple of patients who still say that they develop gastritis, but most doctors in Singapore, as a safety precaution, will still prescribe your omeprazole or your stomach lining protector with arcoxia itself. Okay? Can it be? I read it cannot be taken for more than 3 days. Arcoxia is essentially a simple painkiller that is mostly prescribed for either simple pains or in a hospital for post-op pain itself. So we generally don't try to increase it for 3 to 5 days. I sometimes give my patients up to 2 weeks. We try not to increase the duration because it does. I mean, the more you take it, the more load and burden it has on the body. The risk of heart and kidney side effects are there. Okay. Will long-term use of painkiller creams was okay? I think you mentioned it. How do doctors decide what pain medication to prescribe? Okay, so most of us, we go by the WHO ladder of pain. Okay, so this WHO ladder was initially drawn up for cancer pain management, but we found that this is logical for most patients suffering in pain. So we start with the simplest, Panadol, right? And most of the time Panadol does not work. Then we use it in combination. And most of us avoid anti-inflammatories unless the patient is young or the patient is post-op, or what we call post-surgical. I generally jump from Panadol straight to Tramadol as a combination. Okay, and that is to solve the simple part of the pain. And then with the neuropathic part or the nerve part of the pain, I will start the neuropathic medication itself. Okay, so that's essentially it. I will not even think about the strong opioids, for example, because 90% of us do not need opioids. Of course, if the pain is not controlled by the medication, then I have to take a look at the diagnosis again. I have to consider if the patient is suitable for pain injections to help with the medications. Now, the medications may help with about 20-30% sometimes. Okay, if in good outcomes, maybe even up to 60 to 80% of most cases. But let's say that ones that do not work so well, the 20 to 30%, then we have to think about whether pain interventions will help. Okay? Yeah.
Okay, thank you very much, Dr. Phang.